I've got three fantastic speakers, all of whom I'm privileged to say are colleagues at Imperial. All are a consultant anaesthetist, and they're going to be talking about paediatric major hemorrhage in different settings.
I am a vascular anaesthetist by trade and head of vascular surgery, and so my consumption of blood products is possibly higher than the trauma service's consumption of blood products, unfortunately. And my calls to the major trauma service and to the vascular and blood transfusion units and to FATs is a weekly basis thing. So thank you very much. I wanted to talk to you a little bit, something slightly different about paediatric trauma, and something that I was integrally involved in alongside people like Rachel and Sarah. And this was talking about being silver command in anaesthesia when a major incident alert goes out. So for those of you who aren't really sure, what is a major incident? A major incident is any event whose impact cannot be handled within the routine service arrangements of the NHS. It's almost like a big bang thing. It happens as a single large-scale event. It can happen at any time of the day, and it is completely something that we aren't expecting necessarily. And so one or two of these events that you might recognise are things like the Grenfell fire in the tower, and the Manchester Arena, which was much more recent. It means that there's an escalating pressure over and above what we do on a normal day, even in a major trauma centre like St Mary's and Imperial. But we have massive pre-planning that goes ahead to know what we can do about these risks, and this is part of the kind of process that Fats and Julia are involved in when it comes to planning for major events, major incidents, when it comes to the blood transfusion service. So just as a small reminder, the Grenfell tower fire happened on the 14th of June in 2017, and just as a kind of appreciation of what was going on, 72 people lost their lives that day or within the coming days. It is the deadliest UK residential fire that has ever happened in modern history. And for us, as a major trauma unit, we were seeing casualties presenting with severe burns, smoke inhalation, and lots of blast type injuries from jumping. Lots of hospitals received the major incident alert and mobilised simultaneously, including for centres that needed to look after paediatric patients, of which St Mary's was the one on site. And then the theatre trauma mobilisation is something that we do at very short notice, and there is a kind of specific way that goes out. On that night, I was second on call for anaesthetics. My first on-call colleague was in the building already, dealing with an operation that was happening in theatres. She got a bit of a heads up from the ED department that something was going on and that something was about to happen. She gave me a call and said, Sadie, I think something's about to not go right. I think a major incident's about to be declared. Can you come into the hospital? So I made my way in before the major incident alerts went out to my colleagues at St Mary's. And this is the normal cascade for our activation in theatres and for the major incident alert at Imperial, which is we declare a major incident. The switchboard then cascades that to everybody. It goes through the system that it will phone all consultants, asking us for an answer to whether we will attend and how long it will take us to attend and which hospital we'll be attending to. Now, lots of us are cross-site consultants. We cross sites at Imperial, Charing Cross, St Mary's, and the Hammersmith Hospital. This call went out to Charing Cross and St Mary's because we are the two sites with an acute emergency department, and so teams will be flooding into both sites at the same time. For us in anaesthetics, our gold command, which is the first consultant on site in the hospital, will go down to ED to coordinate what is happening in the emergency department and to ensure that the services are all up and running in terms of what might be needed, and to gather the information as to how many casualties we're expecting. And we're getting all of this information from the scene coordinators. For me, at Silver Command, I arrive in the hospital and I mobilise myself to the theatre site and into the theatre suite. There I will meet with my theatre coordinators, which are the scrub nurses on site, work out what's happening in our theatres across all of our theatre complexes, including our labour ward, which needs to keep running. We can't stop the running of our labour ward because of a major incident, and we need to make sure that they have enough people and the appropriate people on board to keep that service going. And what happens is then people start to come in. We note that they are in the building so that we can work out where to best place them, and people congregate in a single area so that they can receive information from myself on that day or that night as Silver Command. What we do is we assign people into each of the theatres. We ask for the ODPs and our scrub nurses to ensure that they have all the kit and trays that might needed for a major trauma. And in this case, for Grenfell, we were very concerned that we would receive a huge number of paediatric trauma. And so we made sure that our paediatric anaesthetists were the first in line to draw up their kit and make sure that they had everything that they had needed and were ready for it. And in the process of a major incident, the blood bank is also activated, and we ensure that we have a blood monitor that speaks directly to the blood lab so they're fully aware of every situation that we are in. So here I am, theatre command and control, and what we're doing is asking for a single point of contact for all of our theatre activity. If a major incident occurs during the working day, we tend to work out what's happening in each theatres and draw a kind of a master plan as to when those theatres will be finished. If a case is in the anaesthetic room and hasn't yet been anaesthetised, we would stop it from being anaesthetised and send the patient back to the ward. Our medical colleagues on the wards and our surgical colleagues who are not operating will come into the hospital and ensure that they can increase the discharge capacity of our hospital in order to make beds. And the same thing is happening on our intensive care unit. And the intensive care unit, as anaesthetists, often as the intensive care unit, we're not just providing anaesthesia for major trauma, but we're also providing the support to transport patients from one intensive care unit to another that are requiring a ventilated transfer, and that's just to make capacity within the major trauma centre. And that requires a huge amount of escalation of staff and equipment. We need to make sure all of that equipment and stuff is in the right place. We do regular sit reps to our command structure. So we are hearing from Gold Command of the hospital. We're hearing from Gold Command on scene. We're also hearing from Gold Command within the ED departments, within the specialist areas, and all of that information is then disseminated back to the team sitting, waiting to be told what to do next. We prepare for a surgical surge, and so we don't know exactly what the injuries will be. We don't know how many theatres we might need to open immediately. So we open all of our available theatres. We make sure they're all prepared to be ready and ready to go in the event of needing to. And we ensure that the surgeons are aware, particularly the major trauma surgeons are aware of where they might need to be, and ensuring that the right type of surgeon is involved with the right case is part of that kind of Gold Command, Silver Command structure, which also exists for the surgeons as well as the ED and anaesthetic teams. If it was working during the day, we would cancel our elective lists immediately, and we redeploy any staff that are on leave or off duty and ask them to come in if that's what is needed. What we do is a lot of crowd control. When these things happen, our teams want to come in, they want to help. We've been trained to help. We've been trained to get things going and make sure we can get the best outcomes for our patients and be supportive in the right bit of the environment. So people like Sarah, for example, though consultant anaesthetist and consultant intensivist, she might be called in by HEMS, and that's the right place for her to be. So we just need to ensure that everybody is in the right place. We need to make sure all of our equipment is ready. So we have in St Mary's, we have three Belmonts in theatres. We make sure that they're all up and running and have been primed and ready to go. We are very lucky at Imperial to have a blood fridge within our theatres, and that will be continuously stocked as we use the stock, and we inform the lab of the stock use. And in this case for Grenfell, we are talking about paediatric specific equipment also being made ready using the Belmont for very small children is a difficult one. So sometimes blood has to be syringed in, and we just need to make sure we have the right number of people on board to do that. I'm not going to talk about damage control surgery because Rachel has said it very eloquently. What we're here to do in our theatre environment is to ensure that we have control of our hemorrhage, and we might do some temporary closure in order to get our patients warm, filled, and steady, so that they can go up to ITU, where they will have their physiology optimized and then return to theatre when necessary. Paediatric trauma, much like what Sarah said, is really, really important to understand. Children are not small adults. We cannot treat them in the same way. It's not just about the mils per kilo. It's also about appreciating that they have, as Sarah said, different body surface area to mass ratio. They become hypothermic incredibly quickly. They become hypokalemic incredibly quickly. So our point of care testing in paediatric trauma is often much more frequent than in adult trauma, and in some cases, every 10 or 15 minutes, we're running a gas or a TEG. And often injuries are hidden in children. They hold on to their kind of baseline physiology for a long time and then fall off that cliff. And that's where we start to worry significantly about not recognizing injury. So that impact of what might seem like a child that comes in with a few kind of soot marks across their body, or is covered in in blankets and things like that, we really need to kind of take all of those off, make a quick assessment, and then try to keep them warm as quickly as possible. When we manage pediatric trauma in theatre, we have, again, like I said, different equipment. We're looking at different types of airway, different types of access. Temperature is incredibly important in the condition of the Grenfell Tower. We receive burns patients. Having done burns anesthesia, it's an environment that's very difficult to work in, but it's so important for our patients to prevent their body fluid losses from exposure to cold environments, to stop them from getting cold really quickly. And we're talking about, in burns patients, you can lose 1 or 2 degrees every 30 minutes. And so we're absolutely forcing hot air into the theatres at this point. We turn all of our bear huggers on, we turn up the temperature in our theatres, and in very small children, we put overhead kind of heating devices on to minimize the heat loss. And so, like I said, everything's covered by monitoring and drugs as frequently as possible. In children, we activate major hemorrhage protocols really early, and in burns patients, and particularly burns in children, if there is any clinical suspicion of a significant burn, we will start to mobilize and start giving blood products really quickly. And those blood products tend to be the coagulation products, things that will stay in the circulation, things like FFP, cryoprecipitate, because they give us the volume in children, even though they haven't lost the hemoglobin necessarily. But we need to keep their fluid volumes and their hypovolemic state at bay. Tranexamic acid is a big part of what we do, and communication in burns victims is paramount, because we're talking across teams. We're not talking just about surgical injuries that require a trauma surgeon, but we're also talking about plastics and orthoplastics injuries that are often much more important. And in the coming days of people who have burns injuries, they're more likely to get infections, and our conversations with intensive care and microbiologists, as well as our blood transfusion services, become paramountly important when managing these patients. Airway burns is another thing that we see a lot in things like the Grenfell fire, people inhaling hot fumes. You might not necessarily note it on their faces. They might not have soot and things like that, but they have inhaled hot fumes, and that will mean that they've got bleeding and fluid losses within their lung parenchyma, and that means that their airway is swollen. We need to get tubes down, ET tubes down these patients really, really quickly. They lose their airways quickly, and that becomes a kind of vicious cycle and a risk of kind of cardiac arrest due to hypoxia. In children with burns trauma, we're looking at their total body surface area, and we use the Browder lung chart to work out what body surface area we're dealing with in terms of burns, and then manage their fluid resuscitation based on the body surface area that has been injured. Like I said, we're using the TEG and the ROTEM to help us really triangulate exactly what products to give in these children. Damage control resuscitation. Rachel talked about the diamond, and we talk about the diamond a lot. For us, the lethal triad is still kind of easy to come to grips with. As anaesthetists, we've been using it for a long time, and we use it for appreciating what at every step where we are. So every 15 minutes, we're going to check what the patient's temperature is, we're going to check what the acid levels are, and we're going to check whether they're coagulopathic and treat each one of those items as a priority. Paediatric transfusion, it is so dependent on what is going on. It depends on, Rachel described a case study of a child that had sustained significant abdominal visceral organ injury. In burns patients, we see skin burns of first, second, and third degree, and parenchymal lung injuries, and they often need huge amounts of FFP and cryoprecipitate, as well as albumin and other fluids on top of blood. And we continue to use things like calcium, and we aim to keep our ionized calcium on our gases above 1.2 and our fibrinogen above 2 grams per litre. So kind of in summary, and Fat said it, I was simulation lead for 10 years. I have spent a long time prepping our teams for major incidents, prepping our teams for the COVID pandemic, ensuring that everybody knew where they needed to be, and doing a lot of time process mapping. And we learn huge amounts from every incident that occurred. In 2017, we had more than one, and we dealt with it. We had 3 that year, which you will remember. And each time we gain some important information. So we do a lot of formal hot and cold debriefing, and that allows us to rejig the major incident plan to ensure that we are prepared for anything that comes through the door. Most importantly, is to look after our teams, to ensure that they are well looked after, because it is a massive emotional burden upon us. And we often forget that we are the second victim in major incidents. We have seen some horrific things, and even people who haven't physically been in the room will relate to what they were doing that day in the labs, in our intensive care units, in our other areas, and they have directly been affected by this. And so we need to make sure that the emotional load of this kind of thing and the staff fatigue associated with major incidents like this are recognised, and we look after our patients and ourselves psychologically. So I've written here what the lessons we learned from the Grenfell incident was, but you can see here of the top 6, and the top 6, number 4 is blood bank communication, one of the most single critical logistical links for us in theatre, and has played a major part in my life, and continues to ensure that we can deliver the best care we can for our patients when a major incident does occur. This is our HEMS team, London HEMS team, some of the guys who work with us in theatres. And what I would like to say is, when we're dealing with paediatric trauma, we really need to have those children-specific protocols and equipment and dosing, just like Sarah showed you, because they're not little adults. So that's my take-home message. And remember each other, that's the important bit.
Thanks, Sadie, for an amazing talk.